In this video, I'm going to talk about the human uterine as well as the ovarian disorders. But before doing that, I would like to first go over the anatomy of the female reproductive tract, then discuss the physiology of the menstruation cycle, and then after that I will go over the disorders. And the reason for that I would like to provide this review is that it's easier to understand some of the disorders after knowing the physiology or the anatomy of the reproductive tract. So there are ligaments that are attached to the female reproductive tract, and you should be familiar with those. So the first one is the suspensory ligament, which connects the ovary to the lateral pelvic wall. So this is called suspensory ligament. And this ligament contains the ovarian vessel. So if there is a plan on cutting the ovary out in a patient, you will first have to ligate the vessel in the suspensory ligament to avoid bleeding from the ovary. The next ligament is called cardinal or lateral cervical ligament, which, as the name implies, connects the lateral cervix to the pelvic wall. And so again, the name for this is cardinal or lateral cervical ligament. And here in this ligament there is a uterine vessel, and thus if you're planning on cutting out the uterus, then you will have to ligate the vessels inside the cardinal ligament. Next we have the broad ligament, which connects the uterus, ovaries, and the fallopian tubules to the lateral pelvic wall. And then the final ligament is the round ligament, which attaches the fundus of the uterus to the labia majora. So this is a round ligament. So now that we are done with the anatomy of the female reproductive tract, next I would like to go over the incidence and the prognosis of different cancers. So for the incidence, which means that the number of new cases that are discovered every year, endometrial cancer is number 1, and then after that is the ovarian, and then after that is the cervical. So these incidences are for the United States, while worldwide cervical cancer is the most common one. And then for the prognosis, ovarian is number 1, then after that cervical, and then endometrial. And the ovarian cancer has the worst prognosis. Now, if you need a memory aid to memorize the order of these tissues, what you can do is that ovarian and cervical are always one after the other. So ovarian, cervical, ovarian, cervical. And then for the incidence, you put endometrial first, and then for the prognosis, you put endometrial last. So next I will go over the physiology of the menstrual cycle. So I don't want to go into too much details here because I've already discussed all these steps in a different video, but I'm just gonna quickly summarize. So here we have the proliferative versus the luteal phase, and during the proliferative phase, increased estrogen as well as the increased luteinizing hormone will induce ovulation and the egg will be released. Later on, if there is fertilization, there is increased production of the human chorionic gonadotropin, which acts similar to the luteinizing hormone, help maintain the corpus luteum, and therefore the levels of progesterone and estrogen will remain high, and thus the pregnancy can be continued. However, if there is no fertilization, then there is no HCG to help maintain the corpus luteum, so the levels of progesterone and estrogen will drop, and thus menstruation will occur, and all the uterine wall will start to collapse. So here I have the drawing of the uterine wall. The wall keeps on increasing in size, while during the secretory phase, if the progesterone drops, the wall starts to shed and cause menstruation. So here you can see that the Graafian follicles will later on release the egg. So here we have the ovulation step. And then if corpus luteum is degenerating, then progesterone will drop and cause shedding of the uterine wall. So there is a condition called Mittel-Schmerz, or also known as ovulation / mid-cycle pain. And this pain is due to the ovulation. So when there is ovulation, if there is some blood from the ruptured follicle, then there could be the peritoneal inflammation, which can mimic the appendicitis. So this condition is referred to as Mittel-Schmerz or ovulation / mid-cycle pain. Alright, now that I've discussed the physiology of the menstruation cycle, then it's easier to go over different forms of the ovarian cyst. So first we have the follicular cyst. So if the follicle fails to rupture in the midpoint of the menstrual cycle, and if the egg is not released, then it will form a cyst. And this cyst is referred to as a follicular cyst. So this is due to the failure of the rupture of follicle during mid-cycle. On the other hand, if the follicle is ruptured and the egg is released, so it will form the corpus luteum, which I've shown you right here. So the egg is already released and the corpus luteum is formed. Now the opening from where the egg was released, if this opening is closed up somehow, then again it can be forming a cyst, and this cyst is referred to as corpus luteum cyst. So therefore, opening of the egg seals off and fluids accumulate, and this is referred to as corpus luteum cyst. Next we have the endometrioid cyst. So endometriosis is referred to the presence of the tissue that is normally lining the inside of the uterus outside the uterus. If this uterine tissue is present inside the ovary, then it's referred to as endometrioid or chocolate cyst. And the reason it's given this name is that there is a dark brown blood that is filling the cyst, which resembles the chocolate. Next we have dermoid cyst, which is a teratoma. And if you recall, teratoma is made of all three germ layers, the endoderm, mesoderm, as well as the ectoderm. So therefore, these cysts are filled with hair, teeth, bone, and cartilage. Theca-lutein cyst is from the excess production of the human chorionic gonadotropin, which is in excess amount in molar pregnancy, as well as with choriocarcinoma. And then finally we have the hemorrhagic cyst, where if the blood vessel inside the cyst wall is ruptured, then it can cause hemorrhage. So if it's blood vessel rupture in cyst wall, then it's called the hemorrhagic cyst. The next ovarian condition is called polycystic ovarian syndrome, and in these patients there is an increased levels of luteinizing hormone, which increases the levels of androgen, and then androgen via the aromatase enzymes is being converted to estrogen, and then estrogen will provide a negative feedback to decrease the level of FSH. So keep in mind, FSH is low in these patients while LH is high. Now, increased level of estrogen can cause increased risk of endometrial carcinoma in these patients. And then increased androgen production can cause growth of small follicles that are arrested during the developmental stage. So it will form a polycystic ovaries. And that is the reason this disorder is referred to as polycystic ovarian syndrome. In addition, due to the excess androgen production, these patients will have an anovulatory cycle, and thus they can be infertile or undergo amenorrhea. They can have hirsutism, acne, and alopecia. And in addition, these patients can present with the diabetes mellitus type 2 due to the insulin resistance in the muscles. So not the fats, but muscles are resistant to insulin, and thus sugar cannot be absorbed, and thus it can cause diabetes mellitus. So resistance to insulin. And then if you're asked on the exam what happens to the level of insulin in these patients, since these patients are resistant to insulin, pancreas will increase insulin production to help compensate for the increased sugar in the blood. And then at the same time, since only the muscles are resistant to insulin but not the fat cells, therefore these patients become fat. And thus obesity is commonly seen with the polycystic ovarian syndrome. So for the same fact, the number one environmental factor to the development of the polycystic ovarian syndrome is obesity. And so the number one treatment option in these patients is weight loss. And it has been shown that losing as much as 5% weight in these patients can help resolve the polycystic ovarian syndrome. So next, I would like to discuss the treatment options in patients with polycystic ovarian syndrome. So your treatment goal is to ameliorate the hyperandrogenic symptoms, the diabetes mellitus type 2 and the cardiovascular side effects, inhibit the endometrial carcinoma from chronic anovulation as well as the excess estrogen. And then these patients do not ovulate and thus require ovulation induction to be able to become pregnant. But at the same time, it's not 100% that they do not ovulate. So they may ovulate at certain times that they don't want it. So it can cause unwanted pregnancy as well. So you may need to provide contraception in those who do not want to become pregnant. So for the treatments of these patients, as I mentioned, number one, weight loss is the best thing to resolve all the conditions that I've listed here. Then you can also provide them with the oral contraceptives, and oral contraceptives is good for the hyperandrogenic symptoms as well as to prevent the endometrial carcinoma and acts as a contraception to prevent the pregnancy. And then if the oral contraceptives are not sufficient to help with the hyperandrogenic symptoms, then you can provide these patients with spironolactone, which is a potassium-sparing diuretic that has anti-androgenic side effects. You can also provide these patients with clomiphene in case they want to ovulate and become pregnant. And then you can finally provide metformin to help with the diabetes mellitus type 2, but at the same time, metformin has been shown to have positive effects in inhibiting the androgenic effects as well as to restore the normal ovulatory cycle. So just to summarize, treatment options that you have for polycystic ovarian syndrome include oral contraceptives, spironolactone, clomiphene to induce ovulation, and finally metformin. The next condition is the pelvic inflammatory disease, and it can be divided into three types. It can affect the fallopian tubules, and it's referred to as salpingitis if it's only affecting the fallopian tubules. So here you can see that there is an inflammation of the fallopian tubules that has been enlarged in size from the infection. Then if it's affecting both the ovaries and the tubes, then it's referred to as salpingo-ophoritis. And then if it's only affecting the uterine cavity, then it's referred to as endometritis, which would be in the uterine cavity. So the common cause of pelvic inflammatory disease is from an ascending infection from the cervix. And chlamydia types D to K is the number one cause, and then after that, gonorrhea as well as bacterial vaginosis are other causes of pelvic inflammatory disease. Now, regarding the chlamydia, I would like to discuss the life cycle with you. So chlamydia is an intracellular organism and cannot make its own ATP, so it has to live inside other cells. It exists in two different forms: elementary bodies, which helps to enter cells, as well as the reticulate bodies, during which time they will replicate. And then they would be released as elementary bodies and then enter inside the cells, turn into reticulate bodies and replicate again. And so the cycle will continue. So the memory aid that I have for you is that elementary bodies will help enter the cells, while the reticulate bodies will help replicate inside the cells. And then the type of discharge that you will see with the chlamydia is a mucopurulent discharge versus gonorrhea, which is causing only a purulent discharge. So again, another memory aid that I have for you is that chlamydia is causing a mucopurulent discharge. Clinical symptoms of these patients include fever, lower quadrant abdominal pain. These patients may also present with a right upper quadrant abdominal pain if they develop perihepatitis, and this condition is referred to as Fitz-Hugh-Curtis syndrome. However, given that only the capsule of the liver is affected but not the actual liver parenchyma, therefore the AST and ALT enzymes will remain normal in these patients. In addition, these patients will present with a discharge. As I discussed earlier, with the chlamydia, it's a mucopurulent discharge, while with gonorrhea, it's a purulent discharge. And then finally, they can also present with a cervical motion tenderness and adnexal tenderness. So in these patients, once you are doing a vaginal examination and you touch the cervix, they will have a severe tenderness on examination. And this is referred to as a cervical motion tenderness, also known as a chandelier sign. And then given that scarring and adhesion formation are common side effects of the pelvic inflammatory disease, therefore complications of this infection also include the ectopic pregnancy, as well as infertility. For the treatment of these patients, you will have to provide antibiotics that are directed against gonorrhea, chlamydia, as well as the vaginal or cervical flora. So for the outpatient treatment, you can provide them with the ceftriaxone as well as doxycycline or azithromycin. So doxycycline or azithromycin, these are used for the treatment of chlamydia, while ceftriaxone is good for the treatment of gonorrhea as well as the other vaginal flora. For inpatient hospitalization, which is usually done for pregnant patients or those that are having vomiting or severe fever and pain, then you will have to treat them with either the gentamicin plus clindamycin or cefoxitin plus doxycycline. So for inpatient treatment, gentamicin plus clindamycin or cefoxitin plus doxycycline. And then one memory aid that I have for you is called Foxy-Doxy for inpatient. So Foxy-Doxy for inpatient treatment. The next condition is endometriosis, which I just discussed earlier with you. It's referred to the presence of the ectopic endometrial gland outside uterus. And so number one, it's commonly found in the ovary, and then it's also found in the uterine ligaments and the other part of the abdomen. So if the endometrial tissue is present in the ovary, do you recall what was the name of it? So it was called the endometrioid or the chocolate cyst. And then for the endometrial tissue that is on the lining of the abdomen, they usually have a powder burn appearance on the laparoscopy. Clinical symptoms of these patients include dysmenorrhea, which means that there are painful menstruations, dyspareunia, which means that there is pain during intercourse, and then dyschezia, which means that there is pain with the defecation. And then a complication of the endometriosis is infertility, and it's not known why presence of endometrial tissue outside its normal place is associated with infertility in these patients. So for the treatment of the endometriosis, you can provide these patients with NSAIDs to help with the pain, or you can provide them with the oral contraceptives. You can provide them with the leuprolide, which is a GnRH agonist that if you provide it in a pulsatile fashion, it will help to resolve the infertility. While if you provide it in a continuous fashion, then it will downregulate the GnRH, and thus therefore it will decrease the FSH and LH in patients with endometriosis. You can also provide them with the danazole, which is a synthetic androgen that suppresses the luteinizing hormone as well as the FSH. You can finally provide them with the anastrozole, which is an aromatase inhibitor that will decrease the level of the estrogen. And so by all of these interventions, by decreasing LH, FSH, as well as estrogen, there would be a decreased growth of the endometrial tissue. The next two conditions are adenomyosis and leiomyoma, and both of these conditions are presenting with the dysmenorrhea, which means that there are painful periods, as well as menorrhagia, which means that there is a prolonged bleeding. And then with adenomyosis, it's from the presence of the endometrial glands within the uterine musculature. However, one big difference, despite it has a similar features, similar clinical presentations to the leiomyoma, is that adenomyosis is a symmetric mass with a uniformly enlarged uterus, versus the leiomyoma, which is asymmetric. So the way I memorize it is that adenomyosis, so A is a symmetric letter. So both sides are the same, while leiomyoma, L, is not a symmetric letter. And so for the treatment of adenomyosis, these patients will have to undergo the hysterectomy. The next condition is leiomyoma, which I just discussed with you, is presenting similar to the adenomyosis with the menorrhagia as well as the dysmenorrhea. And then the other term for leiomyoma is fibroids, which are benign, smooth muscle tumors that grow in response to estrogen, and thus they would increase in size during pregnancy, but then decrease in size with the menopause. Leiomyoma is more commonly seen in African American females between the ages of 20 to 40, and then on histology you will see this whorl pattern of the smooth muscles. Next disorder is leiomyosarcoma, which is also more common, similar to leiomyoma, in African American females, but then one difference is that it's a malignant tumor of the smooth muscles, and then it can recur even with resection, and it's more common in the ages of 50 to 59. And then you should know that leiomyoma does not give rise to the leiomyosarcoma. So again, given this age range, leiomyosarcoma is usually seen in postmenopausal females, and it's an aggressive malignant tumor with a poor prognosis. It has an irregular shape, as I've shown you here, a schematic drawing, and there is usually areas of the coagulative necrosis that is seen in the tumor with the abundant mitosis and atypia on histology. Next, we have the endometrial carcinoma. So given the terminology shown here, carcinoma, this is arising from the epithelium. And it's more common within the age range of 55 to 65, and it's usually being preceded by the endometrial hyperplasia. And risk factors to the development of the endometrial carcinoma include early menarche, late menopause. So if a patient has early menarche, then there would be an early increased levels of estrogen. And if they have a late menopause, again, they will continue to produce estrogen for a longer period of time. So any of these conditions, because they are causing increased estrogen production, can cause endometrial hyperplasia and thus increase the risk of the endometrial carcinoma. Other risk factors include nulliparity, excess estrogen production from an ovarian tumor, estrogen replacement therapy, tamoxifen, as well as conditions that cause chronic anovulation, like for instance polycystic ovarian syndrome. And the other two risk factors that you should also be familiar with are obesity as well as the Lynch syndrome. So Lynch syndrome, also known as hereditary polyposis colorectal carcinoma, is due to mutations in the DNA mismatch repair gene, as a consequence of which these patients are prone to the development of the colorectal as well as endometrial carcinoma. The rest of the conditions that I've listed here increase the level of estrogen without increasing the levels of progesterone, as a consequence of which it increases the risk of the endometrial carcinoma. For instance, as I mentioned earlier, early menarche and late menopause increases the level of exposure to estrogen during lifetime and thus increase the risk of endometrial carcinoma. Tamoxifen is an estrogen receptor antagonist in the breast, so it helps with the treatment of breast carcinoma, but it acts as an estrogen agonist in the endometrial tissues. So again, tamoxifen, because it increases the effect of estrogen, increases the risk of endometrial carcinoma. Nulliparity and chronic anovulation is due to the low level of progesterone in these patients. So patients that have chronic anovulation, they have high estrogen with no opposing progesterone. So therefore it increases again the risk of this type of cancer, versus nulliparity, which means that these patients had no children. During pregnancy, there is increased level of progesterone, but patients that had no kids have low levels of progesterone exposure during their lifetime compared to those who have kids. So nulliparity is again another risk factor to the development of the endometrial carcinoma. And so for the presentation of these patients, they usually present as vaginal bleeding in a post-menopausal female. So now we are done with the discussion of the ovarian and uterine disorders. Here I've listed another condition that is called sarcoma botryoides, and it's neither a uterine disorder nor an ovarian disorder. But given that it's protruding as a mass from the vagina, it's sometimes being confused with a uterine disorder. So I thought I should list it here just to clarify. So sarcoma botryoides, also known as botryoid rhabdomyosarcoma, is a disorder of females of less than 4 years of age that presents as a grape-like mass that protrudes from the vagina. And then on biopsy, you will see cross striations with the positive stain for the desmin. And if you recall, desmin was used for staining of the skeletal muscles. And the reason for that is that this mass is arising from the skeletal muscles of the vagina or the bladder. And thus, given that it's arising from the skeletal muscles, it has the name rhabdomyosarcoma. So just keep that in mind. This mass is not arising from the uterine smooth muscles, but rather from the skeletal muscles of the vagina or the bladder. And that concludes our discussion.